Зворотній відлік така нервова штука.
Good afternoon or good morning. Today we are ready to greet you at the online presentation of the recommendations for organizing services for veterans at the primary healthcare level. And let me introduce our speakers. Joining us today are the reputed speakers such as Kseniia Voznitsyna, Director of the Center for Mental Health and Rehabilitation of Veterans, Lisova, Poliana, Mr. Ruslan Prykhodko, Deputy Minister of the Veterans Affairs of Ukraine for Medicine. He's going to clarify things for us today because we have a couple of questions. And also joining us online will be Anastasiia Khodan, family doctor, co-founder of the Association of the Family Doctors of Ukraine. And there's a lot more titles to every speaker, but we decided to make it short and brief. We will be working in a format of discussion, and I will ask the authors of the Methodological Recommendations, Ms. Anastasiia and Ms. Kseniia, to help us clarify what are the recommendations populated with, what sections do they contain, and let us start with the general question. Why is it really important in general, and how it can be useful for the doctors? And I think that the best one to answer this question will be Ms. Anastasiia, because basically the experts who made their contribution, their biggest contribution, were the family doctors, including Ms. Anastasiia and Mr. Igor Zastavny, because those recommendations are developed for family doctors, but we were trying to recreate a multidisciplinary rehabilitation group so that every doctor, every medic working with the veterans can provide some feedback for the primary link so that the interaction with the veterans can be improved. And Ms. Anastasiia, the floor is yours. Greetings, pleasure seeing you. Thank you for having me. I'm a little bit worried because important people are listening to me, my colleagues, veterans, both male and female, so let me make it simple. And if you have any questions, please ask and I will answer them. So first, we're not developing it as the recommendations. We were studying information available in Ukraine, and it turned out that many organizations, many different institutions have already come up with certain procedures how to work with the veterans. Those were recommendations for the secondary link, for the specialized medical aid, and we realized that it doesn't make a sense to add anything there. There's a lot of information already available in that field, and on top of that, I don't know how to work in the secondary link or specialized medical aids. That's why we decided to work with the primary link. But why? Why didn't we invite the experts to work in the specialized medicine field? If you review the recommendations, or when you do so, I will appreciate any feedback. By the way, well, I apologize. Can I put the slide on the screen so that the people joining us online can see it right away? Well, yeah, it would be just great. You can follow this QR code and download an online version. For a printed version, please contact Veteranka, and we will send the printed version to all the organizations involved. Well, thank you for putting this QR code. It's way easier to work like that. If you open the content and the link, it would be even more easier. So we're explaining it, and I think the majority of people understand it, but still some require additional explanation that the family doctor is an entry point to the healthcare system for the veterans. As long as you're serving, there are one kind of doctors taking care of you. As soon as you become a veteran, whether male or female, you don't know how to continue that route. And as the majority of the population of Ukraine have declarations entered into with their family doctors, those family doctors become the entry points, and they advocate the interests of the veterans and their family members, and that's super cool and convenient because you can easily pick a family doctor. If one doesn't fit you, come find another one. Meet another one whose values you do share. And it's really useful because frequently the family doctors know those people before the war, before the full-scale invasion. It's also important because it helps us to identify changes. People used to be like this and now they're like that. Maybe there are reasons behind that. Maybe they need some additional aid, some help. Well, it's very visible when it comes to mental health condition because we knew those people before and now we see them different. And again, we're guiding the families. We don't guide the people. We don't guide the illnesses. We work with the families, with the real people. And since that aspect of life of a person influences the family in whole, we can help that family in common. And quite frequently, I was asked questions, what a family doctor can do, what is their tool set? They can do a lot, first of all. And secondly, very important is that a family doctor can and should act as advocates of the patients in the healthcare system. When someone doesn't want to receive my patient, or they provide some improper aid, or when they get services that have nothing to do with the scientific background, or when the veterans are being extorted money, the family doctors will be the ones who will have to guide a person. I think many people are breaking into tears as you're saying that, when you say that the family doctor is supposed to be an advocate, because the primary link is sitting on the shoulders of people like you. If I may add a comment, listening to Miss Anastasiia, we have our vision and goals of the role of the family doctor in the system of monitoring of health condition of our defenders. But recently we have taken we held a survey among the veterans when it comes to primary link, and one of the biggest problems, one of the biggest issues was when they contact a family doctor, they don't want to be advocated because people come with certain need, and the family doctor says you need a neuropathologist or you need to undergo a physical rehabilitation, and the veteran is asking, where can I do that? And the most widespread answer is open a National Healthcare Service website and check the contracted institutions. That's surreal. That's not about advocacy or improvement of quality of life. This is what we tried. Yeah, but we're discussing the way the system is supposed to work and the way the best representatives of the system work. But unfortunately, in many institutions, we don't have, you know, everything is being ensured by a human factor, but I think the procedures should be written in such a way that you cannot evade them. But in fact, the veterans, both male and female, sometimes they need a person like that because really there was a lot of complaints, even in a military hospital, when a person comes upon prescription and they're being sent to a private clinic to provide a service. And we cannot rely on family doctors in situations like this, because on top of treating patients, they are supposed to fight their corruption, but everybody needs this procedure when it comes to problems in the medicine. And it's pleasant to hear things like this, because I know patients of Ms. Anastasiia personally, what she proclaims and what she demonstrates with her example. You know, when you find a family doctor for yourself, you will hold on to them. and very little number of people really find time and forces to sign another and another declaration. I'm sorry for interrupting you. Well, this is exactly what I meant by advocacy. It was not about lawyers or court. It was about championing the interests of a person. And one of the principles of the family medicine is the integrity. Many think that integrity is 24/7 provision of medical aid, but it has nothing to do with integrity or consistency. When a veteran comes, we see that we need to guide them to a neurologist, for example, and I suggest you contact this or that neurologist because they know this or that kind of pathology the best, and then come back to me, give me a feedback. What did you get from that consultation? Did you get any additional prescription? What are we supposed to do next? Do we need any additional examination? We're talking the same things, but just in different words. This is exactly what I was meaning. Yes, let me add. Obviously, human factor will be present in those processes. Unfortunately, that's not the most joyful news, but using those recommendations, we wanted to provide the procedures to the people who consciously want to help. That's the first thing. The tools need to be there, and they need to be for the people who take their job responsibly, and they are going to make use of them. But on the flip side, we started writing our methodical recommendations before the full-scale invasion, when the number of veterans did not exceed 350,000. Now the figure is whole different, and even despite providing the specialized aid, all of our team, we ask our patients, we beg them, find your family doctor. That's critically important. The majority of chronic diseases that people get in the combat operations, they are being treated by the primary link. Way lower number of people require those drippers and stationary aid. The majority of pathologies are being treated on an outhouse basis. And this culture of consumption of family medicine, we need to cultivate it. We need to develop it. That's a difficult process. That's a post-Soviet remnant. And family doctors, sometimes they don't have enough time and responsibility, and even sometimes the patients, they treat that aid as something that is not necessary and not important. So in our turn, as the specialists working in the third link, we keep talking about it. We keep trying to implement it in Ukraine. I wanted to add two more things. First, it resonates always with me what Ms. Anastasiia is saying about linking and referral. We were discussing it, that it's important to have a professional community. A community that can share knowledge, their developments. It should be related with or somehow connected with the educational institutions. And the cooler the family doctor is, the more expensive network is their personal network of specialists that they can refer the patients to. And the same applies to others. So this experience, it should be shared in a professional community, and we need a methodological tool and capacity to share our developments with the rest of the world, because we gain the biggest knowledge when it comes to work with the veterans. And another thing that resonates what Ms. Kseniia said, she said that the men, when they get sick, they are capricious, and it works with the veterans as well. So my question was, in fact, well, I wanted to make a short introduction. We started preparing it in the beginning of the year 2021. and the process stalled because of the full-scale invasion, and then a lot of similar materials started emerging, similar in our opinion. And at some moment, we were able to finalize them, to print out those recommendations, because we realized that this material is still not sufficient. And I would like to ask Mr. Ruslan whether you can recall any similar products, probably tell us what's missing now, and what niche can we occupy that, or can we populate? That's one. And another question is, like, we were discussing those recommendations with the doctors. Everything looks great, but you don't always know whether your patient is a veteran or not, whether that people, whether they were in captivity or not, because Kseniia has written a whole section about the former POWs who were released. So if you don't know who's in front of you, how the doctor should act, is there any plan for the merger of registers so that the doctors can see right away whether their patients were in combat operations? Well, I'm a pragmatist and I'm a criticist. I don't live with illusions. I keep working with the problems, always. I live with those problems, and this is my disposition. This is my perspective. I used to look at all of the processes. Talking about the veterans policy in general, unfortunately, today we can state that any problem that exists in the public sphere, no matter is it medical, economic, sport, any sphere, the problem is multiplying when it comes to the veterans, and the Ministry for Veterans Affairs starts working with that problem. Let me give you an example of understanding of position, the way I see the processes. For example, let's take some specific community, and there is a healthcare institution in that community. The institution founded by the local council that appoints the head of the institution and is being contracted by the National Healthcare Service, providing services, the cost of which is being reimbursed by the medical guarantees program contemplated by the state budget. This is the way the healthcare system functions. Those can be communal institutions and private institutions. So let's imagine the situation. Some high-ranking official, like President of Ukraine or a little bit lower, says, like somewhere on TV, that the state ensures free rehabilitation and provision of all of the services to the veterans because it's all contemplated by the medical guarantees program. Last year it was 176 billion, and now another year added 20 more billion. And it looks like a perfect world. We should all be 100% healthy, and everything looks fine. But let's take some specific community, some particular veteran, and somehow they're dissatisfied. And we end up in a situation when they come to an institution because they've heard on TV, like, dude, you were fighting for us. The whole country thanks you, and we cover it for you. And he comes, or they come to an institution, and they're being required some money, or they have a prescription for in like another visit to the doctor in 11 months. And then I start sorting out this procedure. Why does the institution not provide certain kind of aid? Because we didn't contract for this package. Why didn't you contract for this package? Because Ministry of Health outlined very specific conditions. So I come to the Ministry of Health and I ask them, like, why can't they be contracted? The institution is supposed to comply with this or those conditions. They are supposed to comply with them. Let's do it on their end. Everything looks fine, but in this algorithm, in this procedure, there is still a veteran who didn't get their service provided. And so sometimes the institutions just violate the conditions. A veteran came in Vinnytsia. He was a defender of Donetsk airport, and he was then referred to a pharmacy to buy medicines in the amount of 60,000 hryvnia, which were supposed to be covered by the state. Well, there was a commission, there was an investigation, the contract was terminated, but what is the benefit for a veteran here? They didn't get anything. Our task is different. Our task is to make sure the veterans get the quality, accessible, free service, and what's most important, in a timely manner when they need it. That's a global vision. And now we switch from this disposition to the primary link of medicine. Unfortunately, in our country, our capacity is not such as the United States of America, where they have a whole hospital link, the whole hospital infrastructure, which is even bigger for the veterans than for the civil population. But let's rewind it back to the World War II and the construction of this infrastructure. Yeah, but their stuff is like for 40,000. Yeah, but they started building it right after the World War II, when the Soviet Union was hiding all of the veterans who were crippled by the World War II. And in this system, we have one medical space, and we work with the infrastructure that is available to us, which services both civilians and the active servicemen and the veterans. And now we can understand the role of the family doctor, the primary link of medicine. If we take two needs of an average veteran, we can identify two key needs. First is health, second is financial coverage. Where do they work? How do they feed their families? So two key needs. In fact, that it applies to all of the veterans, despite their gender. But again, if they are facing a choice whether to make money or to get treated, obviously everyone would prefer making money, and everyone is neglecting this question. If we create barriers for the veterans, we minimize the possibility of them achieving that doctor. That's a fact, and the higher are the barriers, the more is the number of the barriers, the less is their chance to get treated. And now, using this methodology that was developed, we've identified the first priority: the recuperation of physical and mental health, so that the veterans are being supported during all of their life. And we start analyzing the existing system. Obviously, the family doctors play the key role, with no exaggeration. That's the entry point. And I keep asking this question: who of the officials takes care of me? Is supposed to be a family doctor. And then another question: we have a lot of IDPs, and that's one of the biggest questions the veterans are asking. We come, say, to a Vyshgorod, and we need to find a family doctor, because this is the way system works. We cannot get any prescription without them. And every family doctor that everyone knows and that everyone recommends, that they already have their patient registers full, and that they come to like some doctor, and the doctor, they provide the service in some way. You know, this is this is the package that we've developed in the beginning of this year. It requires quality rethinking and quantity rethinking. But what was the key idea behind it? It improved the rate of the family doctor if they work with a veteran. Okay, how do we identify it? A veteran comes and they make a confession that they're a veteran. Yes, exactly. You said that the electronic system requires some amendments. I'm just asking. There was a discussion, and I can understand this discussion, that all of the patients are supposed to be equal. We don't have to segregate veterans, but at the same time, the veterans act like an indicator of the efficiency of the system. For veterans, there will be more barriers right away. Yeah, but in any case, the program of medical guarantees is based on the illnesses, not the categories. The consequences and the approaches that we use are different. But again, rushing a little bit ahead when it comes to identification of the veterans is critically important. Do we want it? Yes, absolutely. And I had a personal discussion with Ms. Maria Karchevich, the Deputy Minister of Health for Digitalization. That's among the priorities. And there was a reform of medical commissions implemented. Everything was aimed at that. We postponed that issue. But starting with the new year, I will definitely start to intensify my work in this area, because it's an important component. But the essence of the program is such that the primary link healthcare institutions should be contracted for all of the packages to service our veterans. If an institution is contracted, a veteran enters into an agreement with the family doctor, and the family doctor's supposed to provide an extended package. It includes different components that Ms. Kseniia was mentioning, such as arthritis, chronic diseases, neurosystem, PTSD, mental health, cardiovascular health, and individual treatment plan that should be monitored by a family doctor. Nothing fantastic behind it. Within the primary link, it is supposed to be monitored, but today, from the financial perspective, veteran is more attractive for the primary link rather than a civilian in Ukraine. And now let's switch to the numbers. Within this year, contract about 41% of the medical healthcare institutions contracted this package. We have 1,106 institutions contracted for the extended package, and there was 18,000 unique veterans out of 1.5 million. It's not even 20,000, and hence the question, my discussion with National Healthcare Service, like they don't want to get contracted. Okay, everybody wants to get mobilized, but nobody wants to get contracted, right? The biggest trigger for me in this component, just like in other packages when it comes to mental health specialists, whoever you ask, dentists, everybody provides services to the veterans pro bono. Look, I pay money. I haven't seen anybody who provides services pro bono. We're saying, okay, let's not do it pro bono. The government is going to cover it. The state is going to cover it. Well, they don't know because they don't want, because of the difficult reporting or other reasons. And it's a huge problem for us, because today, just a couple of hours ago, I had a meeting with my team whose task is to re-engineer this program to understand where we have gaps and how to fill them, or what barriers to remove to make it work. And Ms. Anastasiia, using this opportunity, I invite your expertise to this group. Ms. Oksana Khodan is already helping us. She was holding trainings for our students, and this is what I preach. We have to train all of the specialists in all spheres, those who work with the veterans. We keep seeing some critical situations. We come to Facebook and you see that somehow somebody failed to provide a proper service to a veteran. We give our social evaluation of how bad it is. We start hating people. And now, not as a representative of the state, but rather as a veteran, I want to ask this question. Before you give some evaluation, what did the state do to make sure the specialists provide services in a different way? First, they should be trained. Well, It's a difficult question, you know. If a person is polite with the veterans and with the others, they act somehow insolent. Well, I don't know if a state can do something. You cannot train a person to be polite. That's done on earlier stages, so to say. It's a question of more profound changes. The way we educate our people, the way our education system works, you're not going to be able to train the street level bureaucrats to be polite unless it's a corporate culture in the hospital. That's you're absolutely right, but that's an element of the policy. There's quite a simple comparison, like my personal one. If we compare, say, communal institutions with the private institutions, if you come, for example, I have 2 children, and the first pregnancy of my wife was supported by a private institution, and if you come to a private institution, they carry you on their hands, like they really appreciate you. And the question, why cannot you be treated like that in a communal institution? Because poverty makes people angry, and the state undertakes too much responsibilities that they don't always fulfill. So we shouldn't count on people providing expensive services for cheap salary. Yeah, but who are the doctors working in the private institutions? They are the same doctors. Yeah, but can we say that every doctor is bad at a state institution, state-controlled institution, or like they are polite in a private clinic, right? Yeah. Well, let me interfere. When it comes to training, you cannot teach people politeness, but you can teach them tools. You can teach them skills. Let me give you an example about the training that was already exercised, and we have been working for 2 years with the Prosecutor's Service of Ukraine. They were working with the people who were set free from captivity. Thanks to that training, the principle of interviews was changed, the ethics was changed, approaches were changed, the questions changed, their skills changed. Their techniques, elements, you cannot teach people politeness, that's right. But there can be clear instructions that replace your personal right to make up things, right? Exactly, this is what we need. We get those requests, how to get those skills. There are specific situations, specific health conditions. They're not so numerous, but they're inherent in the veterans community. But that's the reality. They exist, and that knowledge can be provided. Well, it's not about politeness or empathy, but it's about shaping of culture. Yeah, it's a systemic work, because my favorite saying is that hope is the bad tactics. At the state, we cannot hope that everybody is conscious. There's a huge number of doctors who are great. I'm different than other officials because I talk to a lot of people, and one veteran calls me from Main Directorate of Intelligence. He says, a friend of mine, she's a doctor, she wants to talk to you. She comes to me in tears, and she says, like, there's a lot of questions. I don't know how to answer. I try to help everyone, because the veterans, when they see contacts, when they see an open person, somebody who is ready to hear out to them, and they open up, and the doctors listen, and I say, okay, that's not our task. Just link that, refer that patient to someone else. But it's not like something that applies to the whole system. You're saying that the services are worse here because the payment is worse. Okay, we've improved the situation. Here's the better payment, and we expect better services, but still they don't want. Look, we want to work with the existing system, with the existing problems. It's obvious everyone wants to get better salary. Let's improve salaries for everyone. Yeah, this is exactly what we're talking about. Don't raise the salaries a bit here and a bit there. We're too poor for that. Yeah, our task is to make sure the system works in the way it is. We need to understand how to make sure that system doesn't have gaps when it comes to our defenders. That's the first thing. And secondly, our task, we haven't studied the phenomena of the war and its consequences in full. Plus, there's a lot of postponed consequences, which are not always obvious this or that moment, which require further support. Not only now. That's why we focus on the primary link now, and we support the intensification of capacity with or the reinforcement with methodological recommendations. And in our extended package, there is a requirement for the doctors who get contracted under that package. They have to undergo additional training. We've developed that training. It's currently posted in the platform of National Healthcare Service of Ukraine, and unfortunately only 8,900 family doctors underwent the training by now, and that's an evidence of their interest. But if they need more imperative, we'll add more imperative and we'll exercise monitoring as long as it takes. Maybe we can get involved in imperative manner, because there is a training course at the National Healthcare Service Academy that were put together by Lisova Poliana about concussion, mhGap, and again, they are of a reference nature. But look, when we were developing our course, the first thing our experts did, Oksana Zbigniewa is also involved with their mental health center. The first thing we did, we started analyzing mhGap, and every expert said, like, great program, great program. Why don't people undergo that training? Well, it's a question. Okay, how many family doctors underwent mhGap? At least 30,000 people underwent that training, so I disagree. I was taking part in that training, in this development too, so I'm going to champion it. And in our methodical recommendations, there's a lot that is based on mhGap protocol. Basically, we emphasize that before you do something with the health of a person, maybe lipidogram is not going to be a primary issue. And also, you were discussing the tools, how to fight those improper communication skills. Well, there is such a tool as consistent professional growth, and there is new resolution on the consistent uninterrupted professional growth, and there is a list of items, the list of trainings that doctors are supposed to undergo every 5 years or within 5 years period, including mhGap that contains a lot of communication component, a lot of things in it, and there's a lot about confidentiality ethics. So this tool is already in place and it starts working, so the hope is there. And your national healthcare service course, does it provide those points? Yes, all of the courses provide. Ms. Kseniia, let's talk a little bit about your part, which is very large scale, I would say, within those methodical recommendations. There's a lot of attention to the neurology, including a dedicated section for the POWs, and it's all based on Lisova Poliana experience. So can you please tell us, what is your perspective of this project? Can these methodical recommendations be useful for those who work with Lisova Poliana, or is it the other way around, that Lisova Poliana may be an ambassador for the recommendations? Well, in Lisova Poliana, definitely not, because we've been working with these recommendations for the last couple of years, but when we were writing them, we were trying to add those specific conditions that can the civilians really can get, well, but basically the civilians can get concussed too, but definitely not in the same amounts as veterans. And we wanted to add knowledge about mental health and neurological component, something specific when it comes to mental health, post-traumatic. It's really different. There are really conditions that require specific kind of aid, and the shock wave, the concussion, something invisible, is being cured without scientific basis, and our goal was to teach the doctors what to do other than the drippers. There was a lot dedicated to the back pain. Sometimes it didn't require some in-house help. The family doctors, they're not supposed to be specialists in everything. They need to be guides within the years to come. They need to refer the patients to others. So those methodological recommendations, we added the information to them that is supposed to be useful for the family doctors or the primary league. But let's see how it works. But I think it's going to be useful. There's a lot about prevention. Don't wait for a magic pill. Just stay in touch with the family doctor who is going to guide you how to change your way of life. There's a lot of responsibility vested in the family doctors how to change the way of living of a person, but they really need to be ambassadors of healthy living in the eyes of their patients, and I really want to thank them. I have a short address to the medical institutions. Our mail pigeon is already knocking on your window. Expect for our recommendations, and I'm asking to put the presentation back on screen. Let me cover just a couple of slides, and I will also ask Miss Anastasiia to add a little bit to this discussion, to add a little bit of your expertise when it comes to methodological recommendations, because we've talked about everything seemingly, but very little, in fact, about the content, in my opinion. Now that we all got ourselves familiarized with the content, Ms. Anastasiia, can you tell us about the addendums that can come in handy for the people who work as a doctors, those doctors who will hold those methodological recommendations in their hands? So we have different sections, and please pay attention that we pay to the section that contemplates organization of an aid to a veteran, and it would be good if that first section is being used by the communities or the heads of the healthcare institutions. If a community is interested in having those services function better, maybe this is exactly for them. Maybe it will be more interesting for the family doctors, or so you can skip it or review it. But if you're head of the community, please pay attention to this section. And there is even addendum to this section, which is supposed to help a team who helps a veteran to populate a structure, to understand where are the gaps, where things can be improved, what works well, what should be reinforced, whom can we get engaged. So also there is an addendum to every single section that is in fact a checklist that helps to generalize the text and to work with the veterans. So how can you use them? You can print out the addendums and you can attach them to the ambulatory card of a veteran. That's not my style of work though, because we don't maintain any paper records. We maintain all of the records in online format, in digital format. So you cannot always print it out. You can print out one just to have it in front of your eyes. And again, those addendums don't replace the methodological recommendations. You can read them. You can extract everything you need from them. And to keep them as a reminder, what's in those addendums? You can review them. A lot of things were not added to the addendums, but they're represented as QR codes that you can scan and proceed to the recommendations. For example, when it comes to standards of medical aid in case of tuberculosis, we decided not to add them because they copy what is contained in the resolution of the Ministry of Health. What else should I add about the screening? So it's not screening. It's categorically not screening. Screening contemplates some interference that should be approved at the national level. That's not screening. Those are methodological recommendations for prevention, including prevention, but definitely not screening. What is included in that topic? So where did we get this information? As Katerina said, there was a huge team working on those recommendations starting from the year 2021. Then there was a small pause in the beginning of the 2022 with the beginning of the full-scale invasion. But then we've resumed our operations and we started changing a lot because the style of the war changed, the veterans changed, the medical aid itself changed. The things are changing quickly now. So we were using the data available at the Ministry for Veterans Affairs of the United States of America, Great Britain, and Australia. Why? Because they present the biggest database of studies when it comes to the veterans. Why didn't we take any Ukrainian studies? What studies? Well, after 11 years of war, there are no studies. Well, that hurts. That's the most hurtful. We have experience, we have knowledge, and we don't study it. However, we need to take that niche on the global level. Let me just finish the sentence. Is it good that we were using the British, American, and Australian guidelines? I don't know. It's normal. Do they fit our situation? No, they require adaptation. The war like we have, it didn't exist before. That's why we need our studies. If you are somehow involved in science, please study the situation in Ukraine. We really need it. So as we've checked their recommendations, their studies, there is a comparison of the conditions that are frequent among the veterans, more frequent than among the civilians. And we were providing it in the recommendations, what is inherent in competence and non-competence. And again, if it's all contained in other sources, you won't be able to find it in our recommendations because we decided not to copy things. But again, it's not screening, it's not proven, it's not approved at the national level. And I liked it the way Mr. Ruslan said, it's not rocket science. There is nothing that goes beyond the competency of a family doctor. They don't have to do a heart surgery in ambulatory conditions. There are just things to pay attention to. Mr. Ruslan, we only have 5 minutes left, and before I give you the last 2 minutes each. Also, let me add that there is a feedback form for the specialists who are going to use it, and we are open to hearing out your feedback to see what can be changed, any new ideas, and basically Miss Anastasiia agreed to support mentorship programs when it comes to, in case of any questions about methodological recommendations, in case any family doctors have them. Well, I've already agreed. Okay, we're not going to give your phone number to everyone. Well, let me add this minute for a joke. Hopefully that's not my last minute, but at least within this press conference. Talking about rocket science, recently I had a meeting and some agreements with the Polish friends, and I was seeing one of the guru of ophthalmology. Unfortunately, we have a lot of combined wounds where sight is impaired. I focus a lot on this. I have social projects running, and there is such a professor, Professor Radok. He's not only professor of the Lublin Ophthalmological University. He is also a director of the National Bank of the iris transplantation. Basically, in Ukraine, we don't even have a legislation. We don't have this field at all. He said that they will share their experience with our doctors. They will provide all the methodology, share all of the skills and knowledge. And still, he tells me it's not rocket science. Anyway, so some surgeries that you talk about are not rocket science as well, because the world is way more complex. So talking about the studies do not exist. They are numerous, and if you check different international donors, projects, everybody funds studies. Whenever I come, they say, we were studying the veterans policy, and I'm like, well, you've spent millions of dollars for some studies. Well, medical studies and the studies of the veterans policy are whole different things. Yeah, but the partner countries report to their governments that the money of the taxpayers were spent for the studies in Ukraine, and we try to systematize this term because a veteran sounds very cool and very fashionable for the partners and financially fashionable, but there should be a systemic influence on the policies, on everything related to the veterans. So primary link is a priority for us. It's unchanged. We are going to make more amendments and transformations to the existing programs. I want to thank all of the developers team for their methodological recommendations. We'll get engaged when it comes to our administrative vertical. We are going to disseminate it among the family doctors. We'll ensure the coverage on our end, and we're open for feedback about what needs to be changed, what needs to be improved. We are open from the perspective of the expertise. We need more expertise. We don't think we're the most clever. We're looking for expertise. We look for support when it comes to search for solutions that are supposed to change the efficiency of the primary link of the medicine on a systemic level for our veterans. Thank you. Thank you. And the words by Ms. Kseniia. And then please put the slide with the authors. Well, we are going to continue our enlightenment and education function. We are going to tell that evidence-based medicine is important. We keep saying it to all of our veterans. And on the other hand, we are ready to get involved. Katrina, if you will need it when it comes to some specialized topics content in those methodological recommendations, if you will need some small niche trainings, we are ready to get involved. If a community of family doctors will need it, and one way or another, I still champion this position that the knowledge and specifics are never sufficient. It's there among the Ukrainian specialists, but it's not shaped as a studies. And when we ask our foreign partners who come to Lisova, Poliana, they want to give us trainings, they want to teach us, and we ask them, give us money for the study, and we are going to study our situation. And they disappear. Yeah, because the studies are expensive. The clinical studies of the military and the veterans is expensive, but that's really a necessary component, hopefully. I want to thank everyone. I want to thank you, Ms. Anastasiia, Mr. Ruslan, Ms. Kseniia. On this slide, you can see who were the experts, the authors of our methodological recommendations. And at this slide, let us finalize our press conference. Thank you for joining us online and offline. We will appreciate any feedback, and for printed versions of the recommendations, please contact Veteranka. Find our contacts at our website.